मैम प्लीज अपना माइक अनम्यूट कीजिएगा बोलने से पहले।
Assalamu alaikum and a very good afternoon to all of you. My name is Dr. Tinsa Khalid, working as an intern in Peds Medicine Department of Yakut National Hospital and Medical College. First of all, it's an honor itself to honor this beautiful audience who has gathered here and on Zoom. Thank you all for giving us your prize time and joining us in this professional forum, which has an objective of covering all academic and practice-related relevant aspects of metabolic disorders in children in Pakistan. Before we further advance into the day, I would like to call Dr. Sheikh Ali Masood to recite some verses from Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم تبارك الذي بيده الملك وهو على كل شيء قدير الذي خلق الموت والحياة ليبلوكم أيكم أحسن عملا وهو العزيز الغفور الذي خلق 7 سماوات طباقا ما ترى في خلق الرحمن من تفاوت فارجع البصر هل ترى من فطور ثم ارجع البصر كرتين ينقلب إليك البصر خاسئا وهو حسير ولقد زينا السماء الدنيا بمصابيح وجعلناها رجوما للشياطين وأعتدنا لهم عذاب السعير صدق الله العظيم.
Jazakallah, Dr. Ali. This is the first MDT formed for metabolic disorder, which is led by Dr. Shabir Ahmed Malik, who is a senior consultant pediatric, neonatology and metabolic consultant disorder in Yakut National Hospital and Medical College. Member of this team includes me, Dr. Sheikh Ali Masood, Dr. Madiha Hussain, working as residents in Yakut National Hospital and Medical College, and Hamna Jamal, final year MBBS student. I would like to acknowledge the presence of one of our eminent guest members of MDT, who is also a guest speaker for today's CME. I would like to welcome Professor Dr. Ahmed Nadeem Abbasi, who is HOD of Radiology in Aga Khan University Hospital and educationist, a forum lead of CTB and TEFF, who will share his brief views about this forum.
Assalamu alaikum. Dr. Abbasi unfortunately is not available today because he had developed sore throat, and so he requested me. My name is Dr. Hamad, and I am one of the mentees of Dr. Abbasi, and hope that my voice is clear and my screen is being shared and you can see it. So we have been working on TAF. TAF is Tumor Board Establishment Forum. So I'm just with short of time. I would like to go through the provided slides very quickly. and try to engage all the questions within my power slides. So I will be sharing the establishment of multidisciplinary team, and the metabolic aspect will be dealt by one of the following speakers, and I will sharing the our experience and international experience. So these are Dr. Abbasi's degree. I just completed my fellowship for radiation oncology 2 weeks back, and I have been one of the co-founders with Dr. Abbasi in TAF, which is Tumor Board Establishment Facilitation Forum. So I have no financial or otherwise conflicts of interest to announce. The thing that we actually advocate is that what we are doing, are we actually um, um, uh, we tend to have a feeling that what we are doing is the best thing, or do we think that we in our status quo with the current practice and with the status quo and not being adopting and not gaining the change and innovation and not accepting it is a problem to us or not? If we think that whatever we're doing is fine, then there is no point of discussion and my presentation is sort of ending here. But if I tend to identify it as a problem and question my practice and say if I'm treating a patient, I will be treating it with a multidisciplinary team discussion, then there must be a problem that is being identified by me. And with a scientific solution that is being coined as early as in the Greek astrology in the 1st century before Christ, they termed these 5 Ws and 1 H. With time and literature that's being quoted, that I'm quoting here in one of the British literature, which was wrote by Kipling, in one of the stories, Just So Stories in 1902, he wrote as a poem that I kept 6 honest serving men. They taught me all I know. Their names are what, why, when, and how, where, and who. So I will be highlighting these multidisciplinary team establishment questions to you. So if I'm trying to develop a multidisciplinary team, what is a multidisciplinary team? The first question arises in my mind. And to address it, it's our team which is trying to address a issue where team comprising of specialists from other discipline and trying to identify it and trying to give us solution to that is a multidisciplinary team. Why it's important? Because it saves lives, and I will be highlighting some of the things in the coming slides. The evidence, the literature does suggest and support our slogan as well. Where do we conduct this activity? Wherever a treatment is being offered, whether it's an oncological treatment or a metabolic treatment or any other where we are interacting with the patient. A team discussion and a team discussion, interdisciplinary or interdisciplinary, always help. When to do it before, especially before embarking any treatment, it's important. Timing is important. Who is going to establish it? Anybody from any rank, from the hierarchy or from the bottom, anybody who thinks that he can bring a change can join the group. And how to establish, it's important that we understand how the change actually occurs. So we are going to go through some of these slides in the where we will discuss these change elements as well. So further 2 questions with the tumor board, MDT, multidisciplinary team, does it really makes the difference, or there's a meaningful outcome to it? And what does the evidence suggest us? And or should we continue what we are doing today? And just carry with our status quo and self-satisfaction with it. Why multidisciplinary tumor board is important, and do we need to bring a cultural change or just make an excuse of our limitations and say that, okay, we can't change anything, so let's do whatever it is available with us, and we can't do anything. So evidence, yes, there are more than 90 publications. We have published a book on that, and 1/3 of the publications are from Pakistan. And it's being accepted at international venues as well. And you can highlight. I want to highlight the medical graduates' involvement within this within our cause and goal. So it's very important that we show our presence at multiple forums. For example, we had communication with Gemini in Italy, Basmalim University, and other hospitals at Turkey, in the UAE. We have the Saha network that is being in coordination with in the Saint Dublin from the island, the Saint Dublin group, and various hospitals at US. The recent most interaction is with the Thomas Jefferson group, and you can appreciate our presence in the Asia, in Europe, in Canada, and in the States as well. So we have been advocating our cause with the tumor board, the multidisciplinary establishment of the tumor boards, because we deal with the tumor. So our MDT is sort of known as tumor boards, and we do advocate that. And before the COVID, we did have international participation as well. We have our group have actually published multiple books on that. We have been advocating it in our research and publication. We have 62 cited publication in order to show our international presence and advocating the multidisciplinary concept to the world on the national and international level. This is our was public. You can see that one third of our patients, when discussed with our peer, had a change in management plan. And this is our slogan, all the young. You can see that all the young and the old, and not the old, but our experienced and mature doctors are advocating the formation of multidisciplinary tumors. You can see the MDT here, which is one of the highlighted thing that will be being talked in the upcoming speakers, by our eminent speakers coming up. And this is what we did for the change. We educated our juniors. So we formed an organization which is known as staff, and we not only aware them, we not only sensitize them, we meet teams from them. And we started our change with involving the public hospitals, the tertiary care hospitals, JPMC, Abasi Shahid, and civil. And by the grace of God, we were able, with the help of the students and graduate students, we established 2 tumor boards, and we have now confirmation of 2 further tumor boards at Dow Medical College. And with Abasi and JPMC, hopefully in few months, we will be bringing and offering tumor boards with their help, inshallah, in their hospitals. So networking is important in order to bring a change, and we have connections at private and um, public hospitals. We are facilitating all over Karachi, and there are some of the highlighted students that initially participated in our goal. And the most important thing is to ask yourself how to bring a change. So let's revisit and learn our professional leadership skills. In order to bring a change, it is very important and imperative that we tend to identify a change is required. And in order to change it, you tend to have leadership skills, because you have to influence others to join you and to bring a change. So we, during our postgraduate training, we try to encompass all these 20 skills in order to learn leadership. But the 4 highlighted are more important: the entrepreneurship mindset, problem solving skills, quality in healthcare, then team building. These are 4 core workshops that one should consider doing in order to be a leader. And guess what? We have been doing City Tumor Board on Sunday at 8 a.m. On bi-weekly schedule. This is non-territorial, non-institutional. Those who want a change in the system, they just gather on one place and discuss their patient in order to improve patient care. At our Hospital, we are conducting 28 multidisciplinary team tumor boards, and most of them are weekly, some of them are fortnightly, and there are weekly and international tumor boards that are you can appreciate on it with the different colors and titles. So we have published, we actually, it's not updated. We have published papers up till now with our undergraduate students. Some of the key two areas are identified. Papers are projecting here, and these are some of the publication in order to bring a change in the society, in order to establish multidisciplinary team culture in Pakistan. And you may join us in our venture. So I'm ending here. This is Dr. Abbasi's slide. So I'm just reading it, what Dr. Abbasi wanted to communicate. I'm in depth to convey my gratitude and a big thanks to my not old friend, but amateur friend, Dr. Shabir Ahmed Malik Saab, who is my and my team's teacher as well. And thanks to MDT junior colleagues, Kinza, Aisha and Hamna. And good luck for your tumor board establishment. And you can always contact us via our blog. Thank you very much.
Thank you so much, Dr. Hamad. This academic forum would be conducting various academic activities in order to sensitize both specialist practitioners and parents and families regarding the importance of early detection of metabolic disorders in children. In this inaugural CME, we would be discussing the rationale and importance of neonatal screening. I would now like to call Dr. Shabir Ahmed Malik to take a lead from here. Those of you who have questions can ask at the end of the session. Every question will be catered accordingly.
Bismillahirrahmanirrahim. Nahamdu wa nasalli ala Rasulil Kareem. And welcome to all our audience from the country and abroad. And it is a good opportunity to share the first inaugural session of the metabolic disorders related program, which is a purely the preventive healthcare program is going to be launched in our country here. So this is the first step, but we are doing here. As you know, every program is having the goal and objectives. So our main goal is to be reduce our national neonatal mortality rate with the help of the preventive introduction of the preventive healthcare delivery systems. And on the top, if you will go to the problem of Pakistan, so you will find a lot of babies we are going to lost in our first few weeks of life. And second, the majority of the babies, those belongs from the rare diseases, especially the metabolic disease and genetics, are unfortunately undiagnosed. And we are ahead behind from the other part of the world where we had already been introduced the neonatal screening program. And it is one of the basic preventive healthcare program where we can cater to decrease our neonatal mortality rate in our country. So this is the first step. And I believe everybody agree on this point. Whenever you are going to introduce any program to improve your quality of work, so you have to be realize what exactly the problem list are there. So I will just share one slide to be realize our status at present. So you can see here, we are among the 10 countries. We are on the top. And as you know, we are very brave nation. When we are realizing anything, we are never giving it up. So our objective and goal for this forum and going to be introduce the institute and the program on national level. and to take out from the list of this 10 in the half to 1 decade. So it is a long journey, but it is the first seed what we are going to go. So we have to be realize it. We are among the 30 country, you can see in the list here. We are almost on the top, and the country, the baby should worst and best to be born. Again, you can see here, and the mortality rate out of the 1,000, we are having the almost 46. So as you know, the newborn screening program is one of the preventive healthcare program, and main objective of this program is to prevent the mortality, morbidity, and disabilities. And this is the main problem where we have to be careful rather than we have to follow the curative healthcare delivery system. We have to be switched over to the preventive healthcare delivery system. So this is the one of the initiative what we are going to take with the relation of the National Newborn Screening Program of Newborn. And the history is not new. Maybe it is new for us, but it's a period of the John F. Kennedy in 1962. But the first introduction of the mandatory newborn screening program in USA from the Massachusetts. And almost now we are 70 years, almost 65, 70 years back. And I believe on the one point, better late than never. So never giving it up. So we have to start this program as early as possible in our country as a national program. And you can see here, it is started there, but there were two changes and two booms came. In 1996, when the DNA analysis started for the cystic fibrosis, and the TMS, the tandem mass spectrography, had been introduced in 2008. So this was the big revolution in our screening program to be determined the cases and confirm the cases. And of course, the father of this screening program was Guthrie. And I remember our postgraduate exam was not completed without the Guthrie related questions. And that time it was not new even, almost 30 years back. And I will go through some pathophysiology. It's a very simple, but our understanding is that this metabolic and genetic disorders are looks like a very complex problem. But believe me, on the basis of my experiences, I can share with you, this is not a big deal if you're going to be understand the pathophysiology of this metabolic disorder, which is usually the simple enzyme deficiencies, simple coenzyme deficiencies you will face, simple mutated gene you will face, simple molecular genetic predisposition you will feel. As a normal person, we are having an understanding of this. For example, this A is a protein and it is going to be changed in an active form in A to B. So this is a protein A and it is going to be changed in active form B. There is one enzyme is using here. This is the only simple thing in that our metabolic disorder conditions where this enzyme is lacking. So what is going on in that? So whenever the enzyme is lacking here, so accumulation of this A will be there. So as you know, it is even literature word, anything axis is a dangerous, whether it is in deficiency axis or the DL axis. So this axis is of course intoxicating our failure of the dependent tissues, and it will present soon, but it is not presenting sometimes usually in the first few days of life. And this is the golden period of the life where we can detect it and to prevent it. And so second thing, whenever this is accessed, ultimately it is going to abnormal formation. That is the another product, another subtract, that is C. This is also unusual for the tissue, so it is also dangerous. And it is not necessary in any condition, for example, PKU and the MSUD and so many conditions are there. where you will not find the total deficiency, absolute deficiency. Sometimes it is a partial deficiency. So of course it will go with the another the formation, somehow formation, but it will be the abnormal, functionally abnormal B. So these all three ultimately going to be damage the our tissue, and it is going with the system. So usually it is taking time to be present. So sometimes you will find our presentation of the metabolic disorder is usually in 6 months of life, 4 months of life, and some are having the more than 1 year. And one thing I'd like to share related with the expanded program of the newborn screening, it is not simple to be screen the baby. It is not enough even to be screen the baby only, because we need the full-fledged setup for it. So it is sometimes a dilemma for the family. How maybe it is positive, maybe it is negative, though nothing unusual for this thing, but sometimes it is going to be false positive. So if you will declare the false positive with a positive case, it will be big dilemma for that baby, and it will be lifelong problem for that baby. So what I mean to say here, that we need the expertise to be read it, to be screened, the screening of the screening result of that baby. It is very important. So we cannot do only the screening and without the full-fledged setup. So our main idea, main aim, main goal for this forum, for this formation of the MDT program in Pakistan, is to be established the full-fledged program in our country. And this is the beautiful view of our one of the place in northern area. And just I would like to share my experiences in Saudi Arabia, where we are proud to be a part of that program, and we had introduced this program there. So just I will highlight the thing. As you know, we had been proved that Saudi Arabia is having the high incidence of inherited metabolic disorder and endocrine disorder. And as you know, that it is very strongly related with the consanguinity. Consanguinity is not uncommon in our country as well, but there is very high rate of the consanguinity in Saudi Arabia, 60%, and Oman was 54.4%. These are the two places where I serve. So I'm well versed about the incidence, prevalence, and the relation of the problems with regards of metabolic disorders. So this is the things which is strongly related, and it is not uncommon in our country as well. And the inborn error of metabolism is strongly linked with the MGT, predisposition of the molecular genetic. And that is the autosomal recessive inheritance. Majority of the metabolic disorder you will find, this is the pattern of the inheritance. And in this one, what you will find, so out of 100%, 25% the chances the baby will be normal only. And 2/3 chances the baby will have some abnormality. In the form of 25% will have the full disease, and 50% will have the carrier. So this carrier maybe it is a big risk in the community if you are not going to be established the screening program, and you are not going to be screened the girls and boys, those are going to be get married, and this will be multiply in future. So this is the second thing what we have to do after the screening program. So we have to be look for the families those are having the high risk. And second thing is the consanguinity, as I mentioned earlier. These are the having the vital role, and a major role is playing in the metabolic disorder and genetic disorder. So what about the Pakistan? What we have to do, because we don't have the exact data here in our country. So what we can do for the beginning, we will assume it with the patchy data. Some data is from Punjab, some from here, some from AKU. So we have to be rely on this data, and we have to be establish our program here on the basis of those articles and those researches to be establish our program, which diseases are common in our country, and we have to introduce those panels. So this is not a story of today what I am doing here. I am doing since last 2007 or 8, I believe. And it is in 1994. the AKU, Alpine University Hospital, there was some people, they had this Mufti, Parveen Mufti and Iqbal, they had done some study there. And what was this feeling? We feel that because of the consensual marriage in this country, these problems are not uncommon, and there is a great need of the establishing diagnostic facilities to confirm the diagnosis, institute, and early treatment for the better outcome and the counseling parents. And it is important to make the diagnosis for the sake of parents who have every right to know why their infant had died and for the purpose of genetic counseling. So our program is also based on this one. And you can see 27 years back, this had been done in our country. That time the visionary people were here. But I don't know what happened during this period, why this program had been stopped there. And again, 2013, you see they say worldwide, this is the metabolic disorder. The babies are suffering this one. The incidence of such diseases is probably much higher in our population due to the intermarriages. So conclusion is that if we are not having even the less consanguinity, because our 70 to 80% populations are belonging from the rural area. And as you know, the rural area, the tribes and all these things are as strong as in Kingdom of Saudi Arabia and the other part of the Gulf country. And although this is the one of the data from the Europe, UK, because we are relying on their data as well. So they are giving 1:2,500 or 5,000 births are suffering with this one. And this is the up to date from 1 in 800 till the 2,500. But in Saudi Arabia, as you know, it was the 1 in 1,000. So what is happening if we are not going to be established this one? Most of the metabolic disorder carrying the serious consequences in the form of the mental retardation, physical handicap, death in the early neonatal period. And you people are having a lot of experiences dealing of this such these categories of patient. And another category is the growth problem. Day and night, you people are seeing in your surgery, in your OPDs, and developmental delayed learning disabilities, retardation, seizure, coma, sometimes leading to death and no sleep. So these are the presentation where we are overlooking the problem of the rare diseases and metabolic disorders. So we are going to be target to be decrease, how to decrease this load. But this is the curative healthcare system. If you will spend a lot of money to be decrease it, so this will not give the much satisfaction as compared to we prevent this one. So because of this, we are badly in need of this program. This is a beautiful scene from our one of the province, that is the Sindh. And a journey to dream. That time when we started the program in KSA, it was looks like now I think this was a really dream. It was what we had done there. So you know the screening criteria we choose from the two places from the American College of the Metabolic and Genetics and Molecular Genetics and the WHO. So WHO program was the some cheap program and based on the old method of screening. But the new program was introduced in 2006 was the DBS dry blood sampling system, and the Tandem MS was going to be introduced in coming 1 to 2 years. So this was the up-to-date program. So we opt the ACMG criteria program in Kingdom of Saudi Arabia, as we are chosen in our country as well. So this was the national newborn screening program there, and we categorize in the three setup there. First, we targeted the high-risk families and patients. So it was the first step what we had done in 1 to 3 years. And then regional tertiary care we had established, and then national program we had finished in 2011. And the program was started in 2006. So this was our 30 centers, and I was among those centers, was one of the regional director of the Northwest area, and it was the biggest area of Kingdom of Saudi Arabia, which I was the catering that one. and 14 our district hospital was catered in that one. And again, I will repeat, I'm proud to be a part of that program. And our scope was the newborn screening was this full-fledged setup of this program. So this was the screening, diagnosis, management, and follow-up of the following diseases. This is the full-fledged program, but we can do it. Otherwise, if only screening will do, it will be not work. It will be not worthy. So we have to be still establish the full-fledged program. So this is our one of the initiative in our LNH, what we are doing. So if at least we had been, we started this program to be just with the outpatient and the indoor admissions, and some people are having the good approach how to deal with this patient. And now the people are, by the time, is going to be familiar with this. And we introduced the emergency management booklet as well. So it is a little bit some comfort zone for our junior and the seniors as well. At least they are aware about the common metabolic disorder, how to deal in the decompensation crisis. And this is the 16 panel we had used in Saudi Arabia. 4 panel was from the endocrine and the 12 was from the metabolic disorder. So this is the way how we are screening the babies. But you see, this is the old method what we introduced in the period of Q3, the standard. So there was the chances of the false positive here too much. So we opt the latest DBS filter, and this is the this is the one where we were using only the drop of the blood and just to be soak it here on the 5 places. And this is enough for the screening of more than even 200, 300. If you want the digital screening, you can do it. Okay. So this was our software, what we had used this one. And it was a well-established program, and we are also introducing in our country as well. And all preliminary basics have been already finished. So and the one thing more, but the center, this is a very important slide what I would like to share with you, is that every center was having this setup. First we were screening the baby, and if the result is going to be positive, so it is positive. So we are positive result means abnormal result. So we were notifying immediately within 24 hours to the physician and starting the treatment. Because, for example, the maple syrup urine disease and PKU and all this, if we are not going to be restrict that food which is going to be harmful for that baby, so it will continuously will have the neurological damage and the other part of the tissue will damage. So this is 24-hour notification we are giving to that one, and then notifying the parent, and then resend the again sample to confirm with the upgraded test. But whenever we are having not remarkable, it is automatically going to the prime. But questionable, some like false positive patient, false negative patient. So how do we deal with those patients? We were having the second track. That one is going to be testing from the same track as the positive track we were using there. So this was the setup, and as you know, this was the collaborated program, and it is a public health program. It is not easy to be deal with the one setup, and even the government setup cannot do it. So one was the provider of the finance, that is the Prince Salman. Now he is the king of the Saudi Arabia. That time he was the prince of the Riyadh. And second, the expertise provider was the King Faisal Special Hospital and Research Center, and we are the one was the manpower provider. So these all collaborative program will reach to the screening of the 16 diseases with the 450, almost 54,787 newborn babies, and 450 cases were detected. So what we had done by this research program and the newborn screening, we had proved it. In Saudi Arabia is having the incidence of 1 in 1,000, 1 in 1,000, okay? So this is the thing what we had done, and our goal is the same what we are going to be achieved in coming 5 years to reach to this level. We must have the data to be give data to give for the references to the other part of the world and the authentic data. So this is the breakdown of that one. So you can see the positive cases because it was the early 20 cases are missing here, and it was later on we added on that one. So the phase 2, when we started, it was the 250 to 350,000 again the newborn, which was the remained patient in the other part of the kingdom. So and the and this is the next what we had done. In this one, the second part, we introduced a 160 hospital, almost all were the Ministry of Health hospital, and it was linked with our 24 center, which were the tertiary care centers. And these tertiary care centers were already were established in the phase 1. As I mentioned, the 450,000 we had already screened on those centers. So what is the idea for this one? To expand the program to whole kingdom, and not a single baby should go home without the screening of the 16 diseases program. Okay. So in the second, we had trained the people and the training program was well established there for the coordinating the pediatrician, assisting the nurses, metabolic dietitian, raise the awareness as I'm doing today, and the health education towards the program for both the healthcare providers and the public, establishing a national electronic database registry, which we are doing in our country as well. And I will just share with you what we had done in last 2 years. Program launched in added that 162 hospitals gradually. And these are the brochure we had used for the mass media, for the public, for the community health education, for our physician, for our junior, for our residents. So we had used this brochure, and this brochure also we are going to be introduced in our local languages according to the province's native languages. So and this is I'm sharing with the second part where I shifted over to the Oman and the Sultan Qaboos University Hospital. So this is the one of the team out of 3 team in a year what we had done, and this is a very small populated country, you know. A part of our Karachi city population, for example, a population of Warangi or North Karachi or New Karachi is equivalent to that the whole population of that country. So this is the 99 every year one team was contributing. So you can imagine how common it is. And the second thing is we have to be introduced in Pakistan. The thing, just there is a technical error there, so just to be resolved it. So we are apologizing for this thing. There is some technical problem. I will just continue. Let him to be finished. Let's see. Okay, it's okay. It's okay. We apologize for the inconvenience. So what we are doing for the Pakistan, you know, we are going to be established the program as same we had done, and it will be our small contribution for this country, and it is due to us. So I reviewed the, this is, can you visualize this slide? You cannot visualize. This is the Statistic Bureau of Pakistan, as I am not visualizing the name of this one. So the data is same. We couldn't recognize any data in this forum. So what to do for our program? What to do? We have to be just think it. We go to right or left? No, we have to be stuck. So as you know, the majority of our problem from the metabolic disorder is going with the three major nutrients, and it is a carbohydrate, which is the commonest one, which we are going to select is the glycogen storage diseases. There are a big panel of the glycogen storage diseases and the galactosemia. The amino acidopathies is the phenylketonuria, tyrosinemia, homocystinuria, maple syrup urine diseases are the common among the amino acidopathy. And the organic acidemia, as our experience in the last 2 years, we are seeing this methylmalonic acidemia, propionic acidemia, isovaleric acidemia, and glutaric acidemia as one. And the fatty metabolism, we are seeing the free fatty acid oxidation defect, glutaric aciduria, and the carnitine deficiency. Lysosomal storage and paroxysmal disorder is not uncommon also in our country, but it is overlooked. And second panel, which is the commonest one, is the hypothyroidism and the congenital adrenal hyperplasia. And as you know, this prenatal studies and diagnostic tool are very important because we can early pick it up. And the second is the diagnostic tool what we are using, the prenatal enzymatic and the ultra-structural analysis of the amniocentesis and CBS, what we are doing in our antenatal clinic here. And the diagnostic tool enzyme study, the electroretinogram, we are doing biopsies, MRI brain, and molecular genetic studies. All these things are available in our country right now, and we are very well versed in doing this. What challenges we had faced and what we will face in our program as well. The early discharge of the babies before 24 hours after the delivery. This is the dilemma when there is a high chances they can miss this one. And second is the difficulties in contacting and recalling the parents or caretaker to collect the second sample, very difficult task. And sometimes we lost the patient because of this simple thing. And the acute shortage of the specialized metabolic pediatrician, genetic counselor, and the metabolic dietitian in our country, as they were also having in that country. So poor awareness of the professionals and the public towards the newborn screening program as well. And the suggested solution, what we had done there, we linked with the mandating the test by law for all babies in Kingdom of Saudi Arabia, running the test as routine procedure like expanded program of immunization. And it is preferably to include the test on the same vaccination book. And the expansion of the program by adding the hemoglobinopathy is there. And third, the providing the extensive training program for physician, dietitian, lab technician, nurses in dealing with the screening and management. And the education of the healthcare professional about the program and the education of the community about the program and involving the decision maker and the community leaders in the program. So gynecology, physician, genetic counselor, these all were involved, and these are the pillar of this program, and they are a stakeholder of this program as well. And the timing of the specimen collection is straightforward in term and the newborn. So we have to do, this is a very near to my heart. And this is the thing what I'm thinking here. This is a guy, you know, this one is one of the Afghani Muslim guy. He was having he lost his hand in a blast on the same day when this Christian lady lost her husband. So and this is a daughter of her. So they decided to donate the hands to this guy, this Muslim guy. And you can see on the side, the very happiest person is here. And he is the one Hindu guy. And this one is I don't remember the name of this doctor. So he was the reconstructive surgeon there. So he is the one, he reconstructs the hands. And you can see the happiness of these three guys and the happiness and the sorrow of this lady. And this we call it the teamwork and achievement. Without this, we cannot achieve any team, anything which we want to be improved. So we have to have our perceptions like this, and we have to move forward. with this attitude, then we can reach to our program to be successful. And what is the conclusion of this all things? This should be the treatable illness, detect in the newborn period, detectable pre-symptomatic, with very important, the pre-symptomatic, not after the symptom when the brain has already been damaged. And the available resources for the diagnosis, treatment, follow-up, all should be present. And the availability of the simple method for the sample collection should be available and trained to the all healthcare worker. And the evidence of the substantial public benefit and acceptance, suitable and simple test method, not the complicated, acceptable cost. This is a very important. And national newborn screening program is a public health. Government should involve. Play your role. Don't complain anything. There is a shortage of the manpower, shortage of the knowledge, shortage of money. No, you have to just play your role and just remove a one mistake. You will save the coming generation like this. Okay, so I will just share my contribution since 2007, what we had done alone here. So a lot of community health program I had done, a lot of things we had done, even I was in abroad, the Oman and AKU collaborated this article published, and the one editorial published in your journal in Pakistan in 2017, I believe. And a lot of workshops I did, not a single medical college I left here in Karachi and other places. And these are the list of this one where we had a repeated workshop related with the metabolic disorder, sharing with the newspaper, mass media, sharing with the rare diseases here in Pakistan, sharing with the big universities. Finally, one thing we achieved after the core group of the metabolic disorder in the Dow University of Health Sciences. This is the one of the bill had been passed from the Sindh Assembly. Not a single baby, every baby has right to be screened in our province. This is the bill which had been already passed because of the big pressure and all this thing had done the Dow University of Health Sciences, the other guys, not the me. But I was proud to be a part of that team when I was coming from abroad, especially for this. So what we achieved after this, was it lost all our efforts, what we had done last 10 years above? No, we are establishing a metabolic genetic department, booklet of emergency management. We have been already introduced registry of the more than 177 patients I have from all over the Pakistan, mandatory screening of all babies for the congenital hypothyroidism we are doing in our center, specific screening in our OPD. I'm doing a lot of patients, sending the samples abroad, and the specialized metabolic APD and dealing of all varieties of metabolic patient, including the admission and rescue management is going to be is doing at our hospital as well. Antenatal evaluation and screening we are doing, establishing the metabolic genetic academic forum now. And we had done many workshops and CME sessions, establishing the Metabolic Genetic Institute very soon, and it has already been started the work. And establishing the MDT of the metabolic disorder has already been started, education and training to resident and fellows, which will ultimately reach to the fellowship program in our country, inshallah. So awareness and motivation program of the National Newborn Screening Program in Pakistan is our aim and objective. What we are doing nowadays, we are seeing this type of the babies in our OPDs and surgeries. I don't want to see this type of the babies. We are having a big pain for seeing these babies, which is high chances we can be prevent this guy. And so our hope, our aim, our dream is to be a brightful future of our coming nation, coming generation. So this is the thing what we need to introduce it here in Pakistan. And like you see, these are the two fountains are there. One is from the Jeddah, this one, and another one was in the Karachi. It was inaugurated, but it is not there. Why it is not there? The start is a very easy thing to be do, but the maintenance is a very important. So we had been lost this one of the precious thing because of our we are not taking the interest to be maintain that one. And this one is maybe more than 40 years or 50 years, it is still there. And every day the people are enjoying on the Cornish. And they do not give up. The beginning is always the hardest. So I will boost to all junior, senior, everyone to play your role only. And this is my journey from the Dominical College till the today I am here. So these are my place of work, the kids, the Kremlin and Toronto as well, and the King Khalid is the Fahd Medical City, Fahd Hospital and Research Center, this is the Sultan Mahmud, and now I'm here. Thank you to all, and we are going to start the question answer session, and thanks.
Those of you who have questions, please they may ask. Unmute the mic and please ask your question. So we have a question for Dr. Shabbir, that is there a newborn screening program at Liaquat National Hospital and Medical College?
Yes, it is not the full-fledged program is there now established, but at least we are doing something is better than nothing. Is TSH screening we are doing, and we are keeping close eyes on the other screening. For example, the auditory hearing screening we are doing here at our hospital, and it is in the pipeline. In future, we'll have the full-fledged high program, but high risk. Those are coming in my OPDs, I'm doing. And a lot of patients, I'm having the families from here to Koita. We had sent a lot of samples to abroad, and we are doing the antenatal screening as well. So antenatal screening also we are doing here. And it is a specific day, is a Friday, but the patient volume is not as I'm expecting to be here. So by the time I feel like this program and the other awareness program, after that we will have the some thing better than at present. Okay. Another question?
Any other questions? Please unmute your mic and you may ask your question. If you are unable to unmute mic, so you may write in the typing bar. We have another question from Dr. Sharmeen Nasser. She's asking for kindly shed some light on the Genetic and Metabolic Institute you are initiating and tell us how can we help you out from our institutes.
Yeah, this question is very good question, and I know Sharmeen is since beginning she is involved in the metabolic disorder. I remember when I was coming from abroad, she is the one that conducting the sessions and all these things and assisting us in our meeting. So very nice to see you here, Sharmeen. And as you know, Sharmeen, one part has already been completed, and that is the DIGS. Dogana Institute of the Genomic Sciences, as you know, it has already been established in our DIMC campus, and it is fully funded from the America. And recently I was there for the part of that meeting as well, and it has already been introduced here. So I was waiting for the Genomic Study Center because it is incomplete program if we are not going to be confirm the diagnosis. Yani only the molecular genetic diagnosis is the answer ultimately. And the enzyme, of course, sometimes it is having the confusion of the cascade where it is the problem, but ultimately we are going with the molecular genetic. So that one is already being established. And the second one, which is just I can share with you because it is, I don't want to disclose the earlier. One thing is already established almost, but it is going to be just introduced or inaugurated soon. That is the National Institute of the Molecular Genetic. So NIMG. So this institute will be in Karachi. Initially, we named it KIMG. So we changed over to the NIMG. And you will see very soon, and we will share you, and especially Dr. Aisha Khan as well. She is in AKU. And I know Dr. Aisha Mehnaz also, she was the part of our team. And I don't remember the other two, three. So this is the thing what we are doing. Inshallah, very soon you will have this one.
We have another question from Dr. Bashir Abru. Which metabolic disorder are tested successfully in Pakistan up to now? Treated, sorry, that's treated.
You see, our very good experiences with the different kinds of the patients. Yani, I remember many families from even Quetta, from where you belong. So one of the patient, his name is Imran, I believe. So he lost the three babies earlier, and one was delivered in some hospital in our city, Karachi, and he brought here on the day of 4th or 5th. But there was a strong history of the loss there. So that baby was unfortunately MSUD. So in your area, we are having the patient of biotin deficiency and MSUD is more there. And few cases of the methylmalonic acidemia and propionic acidemias are coming from Balochistan. And I remember some cases of the homocystinuria, the real cases, and some are the homocystinemia, not the homocystinuria. So these are the one are the common related with your Balochistan area. And our Punjab area, you will have the majority of the patient is having related with the two categories. One is the carbohydrate related problem, and second one is having the, as I mentioned, you methylmalonic and propionic acidemia and homocystinuria. And in our province as well, the same problem, but for KPK, I'm not well aware about that because those patients are not coming here. So these are the situation at present in Pakistan. So biotinase you can successfully, you are treating with a very cheap medicine. Methylmalonic acidemia you are treating with the nutritional support is available here, but very expensive. And now the Baitul Mal is supporting to the parents with the limited resources and underprivileged patients. And this is well established right now. And almost 163 patients are availing this money from there. Okay.
Any other questions? Thank you so much to all those who are congratulating Dr. Shabbir. If you have any questions, please you may ask. Okay, we have another question from Aisha Khan. What is your experience with biotin
Biotin
deficiency? Okay.
Yes. Welcome, Dr. Aisha Khan here. So it is also one big dilemma, Dr. Aisha. We are just seeing the patient late, and unfortunately, our majority of the patient, which we picked up here with the high-risk family screening only, and the patient directly coming with the neurological deficit, and the seizure is the one of the prominent presentation of those patients. The child behaviors in the second one is presenting like this. Sometimes the GI tract is also going to be involved there, and sometimes photosensitivity problem. So, but I can say this one is not the, we cannot revert it 100%, but at least the intractable seizure is going to be controlled, the quality of life is going to be improved, and this is the thing what we are doing here. But my aim is not to deal this all patients the already had been damaged. So our is to be just screen in first 24 hours, and to be result in hand supposed to be in 72 hours, and it is too late to be see the patient after the 72 hours. For example, CH patient, we can't do anything if we are not picking it up in first 72 hours, especially the SAR losing one, the 21 hydroxylase one. So biotinase, yes, it is still challenge, and the big challenge I can say, it is not as sufficient to deal the patient to stop the seizure attack and convulsion attacks, and little bit quality of the life is going to be increased. No, this is not enough. So inshallah, I hope you are the one will actively taking part in our program as well. And I know you people are also doing a lot there in your institution at AKU related with the counseling and other thing. And we are really proud of you people as well.
Okay, we have another question by Dr. Wasim.
Jamal.
Yeah, that how and what is the earliest presentation of any metabolic disorder in neonate in BHU when they refer to newborn to tertiary care?
Yeah, this is a very important question, and our aim is because of this, we are very soon is going to be introduce the teleconsultation, and everything is ready for the teleconsultation place and all things, and the targeted small places of the interior of Sindh we choose. So what we'll do, the newborn period is a very important period where the majority of the patient is going to be missed. There are three ways of the presentation in the newborn. For any babies is going to be present with the prolonged jaundice, exaggerated jaundice. So we call it the neonatal hepatitis-like picture. For example, galactosemia, hereditary fructose intolerance, tyrosinemia, acid lipase deficiencies. These all are presenting in the newborn period with the exaggerated jaundice or hepatitis-like presentation, except the hereditary fructose intolerance, which is usually presenting in the introduction of the fructose at the age of the 4 to 5 months. So this is one of the presentations. Second presentation is the encephalopathy-like picture. Encephalopathy-like picture means the patient is starting with some loss or abnormal pattern of the primitive reflexes, neonatal reflexes. It will trigger you, alarm you, it will give the red flag to you that there is something wrong going on with this newborn baby. So this is the second red flag you have to be take care for those babies. Third one is the electrolyte imbalance. If any baby is going to be not responding with the hypoglycemia, For example, hypoglycemia is one of the commonest one among the electrolyte. So if it is not, it is a refractory and not going to be treated by the traditional way and the protocol guidelines. So it means there is something wrong there. And any baby is having the abnormal movement, anything which is related with even poor sucking and hypoactivity, overactivities. These are the 7 ways of presentation of neonatal metabolic disorder. Okay, so we will have the detailed session for this one. Yeah, you will find in our forum, inshallah, very soon.
We have another question. What is the risk of citrullinemia in grandchildren?
Yeah, I believe this Jamshed is from Jeddah, if I am not wrong. Is it? Jamshed Atik, yes. So I remember the Mariam, his daughter, when she was admitted in the King Abdulaziz Hospital in Jeddah, I believe, and the 6th or 7th day, he called up me to also, my baby is having the sepsis and all these things, and the people are worried what to do with these things. And that time, I think it was our program was not started, the national newborn screening in Kingdom of Saudi Arabia. So that time, that baby was diagnosed the citrullinemia. And this is, as you know, it is one of the urea cycle defect, and the mode of inheritance is the X-linked recessive. So the chances is as the other X-linked recessive is very high. And especially this patient is giving alarm to you whenever going to be delivered will have the respiratory alkalosis rather than sepsis with the metabolic acidosis. And the feature will be the same. So the grandchildren, there is a pedigree and how much you are avoiding this marriages. So this is the one will give the correct answer. If you will give me the pedigree of the first, second, third generation, then it is will be easy. What is the chances of specifically in that one? And as you know, the carrier is always is a female. So we have to be take care for it. Okay, it is transmission is coming from there.
Okay, we have another question from Dr. Shami that if we start with screening the high risk newborn, how much does it cost per patient?
Yeah, this is Dr. Sami, I believe, from the Samros, and it is a great person. One of the I really impressed with his academic interest and all these things. So, Dr. Sami, this it depends upon the panel, how many diseases we are going to be screened. But on average, if we want to be screen the common 6 or 7 diseases, it is cost almost 10,000 Pakistani rupees PKR. And I believe this is a very expensive. So we are just thinking about to be increase the volume. So we have to be use the kit for the majority of the patients. So cost automatically it will come down. So very soon we will have the good news regarding this thing. I was not quite last 2 years, but we were doing a lot of things. And now it is the time to be explored one by one. Inshallah, Dr. Sami, you will have the good news and very concessional and complimentary rate. You will have the screening for the newborn babies for the common diseases, inshallah. Very soon. We are waiting for the response from the fundraisers.
Taking this last question from Dr. Bashir Abro, that earlier the screening of metabolic disorder was supported by some donor agencies. I remember Professor Aisha Mehnaz was supporting Lady to send the samples abroad, and we have made diagnosis of some lipidosis in 2 children. Is that donor or supporting paper sampling available now, sir?
When Dr. Aisha was there in Dow University of Health Sciences, and she was chair the program there, the pediatric program, she had done a lot that time, and her vision was very broad to do something on the national level. But unfortunately, she has already been retired, but still she is very active for this. So that time she was doing, I don't know about the at present what is the program going on there, but I believe Sharmin Nasir is the one well versed about this. But I can say from my center, yes, I'm sending abroad this one, and a lot of patients they had been received the result, which were some are negative, some are positive there. So inshallah, the March is our target is the Balochistan, Dr. Bashir Abdo. So be ready. We will be there, inshallah. Okay, thank you.
Professor Nadeem Abbasi's Professor Nadeem Abbasi's TEFF is an active professional partners of MD-MDT. Thank you so much for your time, Dr. Shabir Ahmed Malik, Dr. Professor Ahmed Nadeem Abbasi for their time, and the audience for their attention. Dr. Hamad, thank you so much for everything. And now it's cake cutting ceremony. Please join us. Thank you so much.
Thanks to all, and really I'm proud of you people. You given the time to be just listen this topic. Usually this topic is not much having the interest to our common audience. So, but I'm very thankful to all of you. Thanks. Have a nice day.
Looking forward for a progressive change. Thank you so much.
Yes. सारे इधर आए और